Hello. Hello. How are you guys? Hello. Okay, right. So, guys, before starting this recall session, there is a brief announcement to be made. PrepLadder is coming with a rapid revision 6.0, which will be released in English version, right? It's a much awaited thing. In this in this English version, we'll be having 260 hours of video lectures and 2,500 high-yield MCQs and concise notes. Okay. So, guys, we'll start with this recall session. Again, this recall session is purely based on the recalls that were given by the students and all, right? It doesn't depict the exact MCQs that were asked in the exam. Okay, right? Okay, guys, starting with the first MCQ, which was given as identify the image which is given below. Okay, what is this image telling you, guys? So when you try to look at this image, this is basically a picture of, there are four options over here: oropharyngeal airway, nasopharyngeal, orotracheal, and tracheostomy tube. Okay. Tracheostomy tube, it can't be. Why? Because it's not with a cuff, right? So it's not a tracheostomy tube. Okay. Apart from that, is it a oropharyngeal airway? No, sir. Oropharyngeal airway or Goodell's airway looks like this. Okay, this is oropharyngeal airway, right? So what is the airway device that is being given over here? Again, we'll go back through the notes and you will get your answer, guys. In the notes, I have already explained you, this is a nasopharyngeal airway, nasopharyngeal airway. Now, guys, please tell me, what is the use of this airway device? When will we use this airway device? When? Imagine a patient is having any oral cavity injury, like the patient had some trauma to his oral cavity. You can't keep the oral cavity patent. You can't keep his airway patent by keeping an oral tube and all. In those patients, you can put a nasopharyngeal airway. Okay? To keep the airway patent in patients who's having any oral cavity trauma, there you can put what? There you can put a nasopharyngeal airway. Okay, so basically this is a nasopharyngeal airway. Normally during anesthesia also, general anesthesia also, we put this airway so that it prevents the back falling of the tongue. Basically in anesthesia, in general anesthesia, normally we go for oropharyngeal airway or Goodell's airway. Okay, so remember, nasopharyngeal airway is usually used in conditions where oropharyngeal airway or Goodell's airway is contraindicated. The reason to use is the same, to keep the airway patent. Okay. Coming to the next MCQ, guys. A patient has no pulse. Basically, I guess it was a pediatric case given. Okay. It simply gives, it's given in the simple language over there. A patient has no pulse and the ECG shows following. What is the next step? Okay, so basically a pediatric patient was pulseless, having this kind of ECG. What is the next step? First of all, guys, if the patient is having no pulse, what is the next thing that you need to do is no pulse. If the patient is having no pulse, and when you connect a defibrillator or the ECG paddles and all, what you will see is when you connect the ECG leads or the defibrillator paddle, if you see any kind of rhythm, you always have to search for only two rhythms, guys. There are only two rhythms which presents with no pulse. Either it is this rhythm or either it is this rhythm. Okay, this rhythm is called as VTAC, ventricular tachycardia, and this rhythm is called as ventricular fibrillation. So whenever the patient is having VT or VF, what is the next step that we need to do, guys? There are four options over here: defibrillate, check the pulse in CPR, synchronize cardioversion, defibrillate CPR and then check the pulse, or epinephrine? First of all, guys, first we'll go with the cardiac arrest algorithm. If you remember the cardiac arrest algorithm, if the person, remember, if the person falls suddenly unconscious, what are the steps of BLS that we are following? Scene safety, check for the response, call for help, check for the pulse and breathing. Okay? If there is no pulse, no breathing, then immediately start your CPR. Okay? So basically, how are you starting your CPR? You start with compressions. Okay? You start with compressions. Now, after giving compressions, now you came to know that the patient is having this kind of pulse. What is the next step that we need to do? If you see this kind of pulse, the next step or the immediate step in the cardiac arrest algorithm, also we have discussed that step, guys. The immediate step is what? Immediate step is you need to you need to give shock to the patient. Basically, you need to give defibrillator. If the patient is having VT or VF, you have to give shock to the patient, right? After giving shock, there is no sense in checking the pulse, guys. You gave the shock to the patient. Why? Because you wanted to revert the rhythm to a normal rhythm. Okay? But it doesn't mean that the pulse will come. The pulse will usually come after you giving compressions. So immediately after giving defibrillation. So first step, if at all you are seeing the patient is in cardiac, the patient is having VT or VF, you have to give shock to the patient. Okay? If it is a pediatric case, and remember, guys, always in cardiac arrest, will you go for a synchronized cardioversion or asynchronized cardioversion? In always in ACLS or BLS, always you go for what? Asynchronized cardioversion. Synchronized cardioversion is usually given for tachyarrhythmia management, not for cardiac arrest. So if at all VT or VF is said, you need to give shock. Then you need to resume your CPR. ठीक है? शॉक के बाद में हमने क्या किया? CPR दिया. उसके बाद में after 2 minutes, now you need to check the rhythm as well as the pulse. Now coming back to our question, guys. Patient is having no pulse and the ECG is showing this. यानी कि it is VT or VF. Will you go for defibrillate, then check the pulse? Defibrillation should be done. But after defibrillation, always first give compression, then check the pulse. So this is wrong. Synchronized cardioversion, no sir, this can't be done. Why? Because synchronized cardioversion is usually done for the management of tachyarrhythmias. Okay, always in cardiac arrest we go for asynchronized cardioversion. Okay, next, will you go for epinephrine? No sir. If at all there is no pulse and the ECG is flatline, the drug of choice is epinephrine. Okay, but not here. The main thing over here is what, guys? The answer over here is you defibrillate, then you give CPR, and then you check for the pulse. Okay. Next, guys. What is the primary purpose of positive end expiratory pressure? Okay, guys. What is the primary purpose of positive end expiratory pressure? That is also called as PEEP. Okay. So while we were discussing about the ventilators and the management, there was a small topic called as PEEP, positive end expiratory pressure. This positive end expiratory pressure is the pressure required to keep a positive pressure in the lungs. Keep a positive pressure. It helps to maintain a positive pressure inside the lungs. How? By keeping the alveoli open. It keeps the alveoli open at the end of expiration. Hence, by keeping the alveoli open at the end of expiration, by keeping the alveoli open at the end of expiration, it is preventing atelectasis. It is preventing atelectasis, right? Apart from that, what else we need to remember? When you do this PEEP, when you give this PEEP, what will happen? It will improve the patient's oxygenation, right? Apart from improving oxygenation of the patient, it will reduce the work of breathing. It will reduce the work of breathing, right? Normally, it is used for ARDS patient. Okay, so basically remember, guys, PEEP, the primary purpose of positive end expiratory pressure is what, guys? to keep the alveoli open at the end of expiration. Positive end expiratory pressure is the pressure required to keep the alveoli open at the end of expiration. Okay. And it prevents atelectasis. So guys, I already told you the importance of PEEP. But again, you also have to keep one thing in your mind, that too much of PEEP is too bad for the patient. That means what? When you give PEEP for a long period of time, or when you increase the PEEP, what will happen? It will basically decrease the venous return, decreasing the cardiac output. PEEP decreases the venous return, decreasing the cardiac output. Okay. So PEEP is one of the important thing. Usually we use this PEEP in ARDS. Okay. Next. So again, PEEP from our rapid revision. This was a slide for PEEP. Right now. Now guys, what is the appropriate method of reversing the muscle relaxant effects of vecuronium when the renal function is normal? I think this was repeated in the INI-CET, but vecuronium was not given in the option. Sorry, vecuronium was not given in the question. In the question, it was given as rocuronium को reverse करने के लिए कौन सा reversal agent लगेगा, ठीक है? But instead of rocuronium, he is asking vecuronium. Now, guys, right? So what we need to understand is either it is rocuronium or vecuronium. Rocuronium or vecuronium can be reversed by two reversal agents. One reversal agent is called as neostigmine. Other reversal agent is called as sugammadex. Okay? I'm not telling these are the two. Remember, neostigmine is most commonly used reversal agent for reversing almost all muscle relaxant. But sugammadex is a selective reversal agent. It's a selective reversal agent which is used commonly for rocuronium and vecuronium. Now, guys, if we go into the rapid revision slide, I had showed you reversal agents. In the reversal agents, again, I showed you neostigmine is the most commonly used. Pyridostigmine is also used. Sugammadex is used for R and V. What is R, guys? R is rocuronium, V is vecuronium. Okay, so sugammadex is the reversal agent that is used for rocuronium and vecuronium. Okay, but sugammadex should be avoided if the patient is having an impaired renal function. Sugammadex reversal agent should be avoided if the patient is having impaired renal function, or basically it should be contraindicated in the patient who's suffering with end stage renal disease. Okay. Now, guys, we are discussing about what? We are discussing about this reversal agent called as sugammadex. Remember, this is the answer for it. Okay. Vecuronium reversal is by, remember, vecuronium can be reversed by neostigmine also, but there are a few side effects with neostigmine. Neostigmine basically, I told you guys in the class also, whenever you give neostigmine as a reversal agent to reverse the effect of muscle relaxant, this neostigmine will cause bradycardia to the patient. Why will it cause bradycardia? Due to the cholinergic side effect, it will cause bradycardia. In order to counteract that side effect, we give neostigmine with glycopyrrolate. So basically, neostigmine is having some cholinergic side effect, but sugammadex is free from cholinergic side effect, as well as it is a very fast acting reversal agent. Very fast acting reversal agent. So it's basically used for rocuronium and vecuronium. Okay. So this was regarding the vecuronium, right? Next, guys. Next question. In which position is the laryngeal inlet aligned in a straight line, typically used for intubation? I think question was not that simple, which is written over here. I think question was quite like this. The question might be like this. Okay. The following is the ideal position used for. Okay. And this was the picture given, guys. This was the picture given, right? What is this position? Or this position is ideally used for which case, guys? Come on. The following is the ideal position used for what? Neurosurgery, sniffing position for intubation, bougie insertion, or neck position for intubation. Come on, guys. What did you write? Or what did you mark the which answer? Which option did you mark? A, B, C, D, neurosurgery, sniffing position, bougie insertion. Again, from the notes only, guys. I know question came from the notes, but this time the questions were a bit tricky. The options were a bit tricky. Okay. Come on, A, B, C, D. What did you write, guys? Right. So basically, guys, just look over here. This position is what? This position is a sniffing position. This is the sniffing position, right? So you have mentioned for intubation. This is the sniffing position. Sniffing position means what? Again, if we look into our notes, it's written sniffing position is what, guys? Sniffing position is the ideal position for intubation, right? Where there is an extension at the atlanto-occipital joint and flexion at the neck. Why do you give extension at the Atlantis? Why do you give this position? Why? Because if you give this position, the oral axis, the laryngeal axis, and the pharyngeal axis come in a straight line. All three axes come in a straight line, and you can see the vocal cords easily to help in intubation. Okay, so this is basically used for what? This is basically used for. This is the ideal position used for intubation. In neurosurgery, why can't be neurosurgery? Guys, remember neurosurgery, there are n number of neurosurgeries and all not for neurosurgeries, you don't require this position. Okay, there are many neurosurgeries, this positioning is not required. For bougie insertion, some of the students were confused like why it can't be bougie insertion. Guys, look over here. Remember, bougie, when do you use bougie? Directly for intubation, will you use bougie? No. When will you use bougie? You are doing laryngoscopy. First of all, for intubation, you give this position, the position called a sniffing position. You do the laryngoscopy. When you're not able to find the vocal cords, then you use bougie. Okay? But for bougie insertion, this positioning is not required. For intubation, this positioning is required. Okay? Next. In an Ambu bag, what is the pressure of the pressure relieving valve? It's not just a valve, it's a pressure relieving valve. What is the pressure? First of all, the pressure of the pressure relieving valve should be always in centimeters of water, not mm of Hg. Okay? Now, there were a few students who were telling, they were confused, saying that whether it was adult or pediatric Ambu bag, we don't understand, sir, that. So anyways, let me make it clear, guys. Adult Ambu, most of the times in adult Ambu, there is no pressure relieving valve. Why? Because in the adults can maintain the pressure and all. Okay? But for pediatrics, pressure relieving valve is mandatory. So 90% it might have given you a picture of the pediatric Ambu bag, right, showing a pressure relieving valve, right? And what's the pressure inside the pressure relieving valve? What's the pressure of the pressure relieving valve, guys? It is 30 to 40 centimeters of water. D is the option. 30 to 40 centimeters of water. Okay, that's regarding what? That's regarding the Ambu bag. Now, next question. A 25-year-old patient undergoing some orthopedic surgery under general anesthesia suddenly develops a rise in EtCO2, sudden increase in the end-tidal carbon dioxide. Temperature of the patient is increased. Okay, EtCO2 is increased. Temperature is increased with muscle spasm. It is a classical case of malignant hyperthermia. This patient is having malignant hyperthermia. Again, going back to our slide of malignant hyperthermia. Guys, you remember malignant hyperthermia is what? Abnormal high temperature with increased spasm. Again, I'm just going for the rapid revision notes only, guys. Okay. Abnormal high temperature with violent muscle spasm is called as malignant hyperthermia. It is an autosomal dominant disorder, RYR1 gene. Okay. So anyways, guys, malignant hyperthermia, the question over here is, he's asking which of the following drug leads to the complication of called as malignant hyperthermia. Now, guys, in anesthesia, I told you there is local anesthetic that can cause malignant hyperthermia, which is called as lignocaine. Okay, lignocaine can cause malignant hyperthermia. How about the IV induction agents? IV induction agents, only four are there: propofol, ethambutol, thiopentone, ketamine. No IV induction agent causes malignant hyperthermia. So propofol, ethambutol already ruled out. They cannot cause malignant hyperthermia. Okay, how about the inhalational agent? Almost all inhalational agent causes malignant hyperthermia, but maximum incidence is seen with halothane. Nitrous is usually safe. Nitrous and xenon are usually safe. Okay? They cannot cause malignant hyperthermia. So, which is the one which is causing malignant hyperthermia? It is halothane. And what is the drug of choice for malignant hyperthermia, guys? For malignant hyperthermia, the drug of choice is IV dantrolene sodium, a central acting muscle relaxant. IV dantrolene sodium. That's regarding what? That's regarding the malignant hyperthermia. Okay, again, this was asked and it was in the right. Right. I have just picked up the slide from the rapid revision, guys. Okay. Now next. Next, in the below given diagram, which or what does C2D mark denote? Okay, basically there was a graph of EtCO2, end-tidal carbon dioxide, where they showed C2D mark denotes what phase of the what phase. So guys, remember, again going back to the notes, right? In the rapid review notes, I mentioned the EtCO2 end-tidal carbon dioxide. It is having four phases. The first phase is what, guys? The first phase is the inspiratory baseline. Then comes the second phase. What is the second phase, guys, over here? It is the expiratory upstroke. Then the third phase is what? Alveolar plateau. Alveolar plateau. And the last phase 0 is called as what, guys? Inspiratory downstroke. Okay? In between phase 2 and phase 3, one angle is there, alpha. यानी कि patient over here begins to exhale carbon dioxide. He is exhaling, 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 and at this point, maximum exhalation of carbon dioxide is seen. Hence, this angle called as beta, which is the angle between phase 3 and phase 0. At this angle, we measure the EtCO2. Okay. So guys, anyways, coming back to our question, guys, coming back to our question, right, where he asked what, right, coming back to our question, where he asked, what is C2D? C2D is what, guys, basically, C2D means he is asking about what is this phase called as? This phase is called as what, guys? Alveolar plateau phase. It is the alveolar plateau phase. Okay. Next. Next, guys, one more question from the ACLS BLS. Okay. This is the position used for the patient's whose. Okay. Basically, what is this position? First, we need to identify. The patient is lying in a lateral position. Lateral position, when do you give? If you go to your rapid review notes, guys, rapid review for NEET PG, I gave you this slide over there. I have explained you over there. If the patient is having no pulse, no breathing, no response, the patient is in cardiac arrest. Cardiac arrest patient needs what? CPCR. For CPCR to be done effectively, patient should be in a supine position. Okay, right? You can't give CPR in this position. So next, if there is pulse, but there is no breathing, okay? If there is pulse, but there is no breathing. If pulse is there, but breathing is not there, then you have to just give rescue breaths to the patient. Rescue breaths needs to be given to the patient. Again, in a supine position only. But if the patient is having pulse, patient is having breathing, but he is not responding, and he is unconscious, then what you will do? If he is having pulse and breathing, he is unconscious. That means he might aspirate the things. There might be some fluid he might aspirate. Right? For preventing aspiration and all, what we need to do, pulse is there, breathing is there. You don't need to give CPR. You don't need to give rescue breaths. Just lie the patient in lateral position. Lateral position. That is called as rescue position, guys. So basically, this is the position used for which patients? A, B, C, D, guys. Come on. What's the answer over here? Will you go for this position in a conscious patient? Obviously not, sir. Conscious patient, what is the need? If the patient is conscious, pulse and breathing is present, tell him to sit. It's done. Nothing, right? If the pulse is absent and breathing is absent, this is a cardiac arrest. In supine position only, you have to give CPR. If pulse is absent, breathing is present, pulse is absent, again you have to give compression. That is, breathing is present means that is patient is having only gasping. That also requires CPR. So these three can't be given. In an unconscious patient who's having pulse and breathing, you go for this position. Okay. So answer is what, guys? You go for this position, lateral position in which patients? In patient who is unconscious with pulse breathing present. Okay. Got it? Yatendra is writing B, C and all. Okay. So anyways, unconscious patient with pulse and breathing present. Next, guys. Identify the procedure which is being done over here. Again, either of the two pictures might be given in your exam, guys. Is it an axillary block? Obviously not. Axillary block is usually given over here. Axillary approach of brachial plexus block is not there. Okay. Is it a wrist block? No, sir. It's not a wrist block. Okay. A wrist block will be given at this level. The picture is not like that. Okay. Is it an intrathecal injection? No, sir. What is this? Again, in the notes I have mentioned, guys. What is this? This is basically a Bier's block. How you can say this is a Bier's block? Just look over here. In Bier's block, we apply a tourniquet. Right? Again, in the notes I have explained you what is Bier's block. Okay? Bier's block other name is IVRA. What is IVRA? Intravenous regional anesthesia. In this intravenous regional anesthesia, basically for which patients you go for this procedure? For patients who are not having a good compliance towards the general anesthesia, or patient who don't want general anesthesia for any limb surgeries. It could be upper limb or lower limb surgeries. If it is an upper limb surgery, first what we need to do is we need to raise the patient's hand. We need to raise the patient's hand for how many minutes? For 8 to 10 minutes. Okay. After raising the hand, then we need to apply a tourniquet. For applying a tourniquet, what is the pressure that is being used, guys? The pressure that is being used to apply a tourniquet. If it is an upper limb surgery, the pressure is 50 plus systolic. And if it is a lower limb surgery, the pressure is 100 plus systolic BP. Okay. And after applying this tourniquet over here, right, then what we need to do? We need to place the cannula. As you can see over here, we have placed the IV cannula. And through this IV cannula, we give a local anesthetic, that is lignocaine. We can use lignocaine or prilocaine, but never bupivacaine. Why? Because bupivacaine is never given IV, as it produces cardiotoxicity. Okay. So you can give lignocaine or prilocaine, that will go and that will block this area. Will it go up? No, sir. It won't go up. Okay. Basically, by applying a tourniquet, you are achieving a regional anesthesia. So IVRA is intravenous regional anesthesia, also called as Bier's block. Okay, guys. Right. So hope it was a bit easy. I know it was a bit tricky, guys. This time the questions were a bit tricky, not that much straightforward, but still it came from the notes and all. Okay. Okay, guys, you have given your best. You have given literally your best. You have waited for the NEET PG, it got postponed, then it got rescheduled and all. Right now, don't take any kind of tension and all. Just relax yourself, guys. Okay. Okay, guys. Okay. So this was the this was the recall session, guys. Okay. Okay. So I'll be signing off now. Thank you.